Thank you so much for joining us today at the 2023 San Antonio Breast Cancer Symposium. I'm your host for this advocate chat with Dr. Virginia Borges. My name is Medha Deoras-Sutliff, and it's a privilege for me to be here today and talk to you, Dr. Borges. Dr. Borges is the Deputy Head, Division of Medical Oncology, Director, Breast Cancer Research Program, and Young Women's Breast Cancer Translational Program at the University of Colorado Comprehensive Cancer Center. She focuses on the unique issues of young women at diagnosis through treatment and beyond. This includes specialized management in pregnancy and breast cancer, family planning after breast cancer treatment, and clinical trials from diagnosis to advanced breast cancer treatments. One of Dr. Borges' main areas of research focus is in young women's breast cancer, particularly the interaction of breast cancer and pregnancy. As many of you may know, Dr. Borges is also an excellent collaborator with patient advocates. In her research, she ensures including the patient voice. I was diagnosed with breast cancer twice under the age of 40. Both of at my second diagnosis, it was just 3 months after the birth of my youngest child. So I'm very interested in learning more about your work, Dr. Borges.
Thank you.
Okay, so there are a lot of misconceptions and myths in this area, and I have a feeling it's not all about estrogen. So I'm really thankful for your time, as I've said, and I really am looking forward to learning more. Could we start with maybe setting the stage? Could you share some definitions of what we're talking about here? Young women, breast cancer, postpartum breast cancer, and then maybe give us an idea of some of the statistics and trends on young women in breast cancer, and particularly postpartum breast cancer, or I think it's referenced as PPBC. I may have that wrong, so please correct me.
Oh, you are absolutely right, and I'm happy to tackle all of those topics which are near and dear to my heart. Thank you so much for having me today, and thank you to all of you for listening in on this. Young women's breast cancer, how is that defined? People will pick the age under which they want to call somebody young at breast cancer diagnosis a little bit differently. In the Young Women's Breast Cancer Translational Program, we have historically looked at women aged 45 and under because we wanted to specifically study the interaction of childbearing and breast cancer, and women in the United States have been having their children later and later for over 2 decades now. And so if you really want to be inclusive of what most women are doing with their lives, we had to be a little bit older in how we define young. It didn't have anything to do with my age, but certainly younger than that is still younger, right? We've known for many years that when women are very young at diagnosis, like under 35, those breast cancers also tend to behave a bit differently. But depending on how you parse this out is what you can find, and we'll talk about that. And when I started in this field, it was confusing because there's been historically this term pregnancy-associated breast cancer, where researchers would lump women who were diagnosed while they were pregnant with women who were diagnosed within about a year after completing a childbirth and compare that to all the other women. And that's not what we thought made the most sense based on our review of the data at the time. And it really appeared that there was a difference of women who being diagnosed during pregnant versus young mothers who had already had their child and being diagnosed in those early years of their motherhood, and how the breast cancers were behaving. So we intentionally decided to look at what we called postpartum breast cancer, so different than the older term pregnancy-associated breast cancer. And fast forward now 15 years, and what we have seen is that, sure enough, if a woman is diagnosed while she is pregnant and initiates her treatment during that pregnancy, in the work of many others, our European collaborators, Dr. Hazim, Dr. Amant, they have shown that those women appear to fare equally well as a young woman with a similar breast cancer but not pregnant at her diagnosis. So the pregnancy is neutral to the outcome. The cancer is the cancer. Conversely, if you look at women who are diagnosed after childbirth, either in the early months thereof or even as far out as 5 years since the birth of their last child, we see that those cancers can behave more aggressively. They have a higher likelihood of experiencing a metastatic recurrence and a lower likelihood of being alive and well many years into the future. And that exists whether the breast cancers are ER positive or ER negative, triple negative. We haven't yet really drilled down on the HER2 positive breast cancers, just because historically we didn't always test women for HER2, and so that's something that is in the works for improving our knowledge in that subgroup of patients. But if you look at the majority of breast cancer, ER positive, triple negative, it appears that the influence of having recently had a child causes these cancers to behave more aggressively. We've also seen that if a woman is between 5 and 10 years after her last childbirth, this effect still seems to be there. It's just not as pronounced. And this is all in comparison to a woman who's diagnosed with a similar cancer but either had never had a child or her kids were already teenagers by the time she was diagnosed. And in our most recent publication last year, what we saw is we even compared to women who were 45 to 65 years of age. And, you know, there's a way to flip this data on its head. What we have also seen is that if a woman is young and hasn't had a child yet or ever at the time of her diagnosis, her outcomes look the same as an average age breast cancer. So she doesn't fall into that increased risk of young women's breast cancer. It's just really a matter of identifying who we have to worry about most, who we have to focus on, who we have to answer questions about. And that held true even if the breast cancer was more on the ER negative side. Those women appeared to do better. So there's a positive side of this data. And so that's what we've continued to focus on. Now, you might say, well, why would that happen? Why would there be differences? And this goes to the work of my collaborators over the years, Dr. Tracy Lyons and Dr. Pepper Shadeen. They are both card-carrying scientists, cancer biologists. They understand mechanisms, cells, and things at an incredibly deep level. And Pepper Shadeen had really thought about this many years ago and identified that when a woman has a child, you know, the breast goes through different stages. Where we're young women, we go through puberty, and then our breasts are sort of there. And then we become pregnant, and the breasts change in response to that pregnancy. After childbirth, if a woman chooses to nurse, there's a whole lot more changes when she's going through that phase of lactation. And then whether she never nurses or she nurses, eventually the breast goes back to baseline. That weaning process is called involution. And the science would teach us that involution is itself it's a normal process, but it's a process that is full of a lot of changes that look like inflammation, that look like a wound trying to heal. And if there's a cancer cell in there or a cell that is heading towards becoming a cancer, it can really promote those cells to behave more aggressively. And so we think it's the act of what is going on in the breast and the exposure to this involution environment that causes these cancers to behave more aggressively. And in beautiful work done in the lab, these scientists have proven that point. And then we've looked at it in our patient samples from my clinic, and we've seen that these things appear to really correlate with each other. So we think this is the driving reason why there's a difference between how cancers can behave depending on where the woman is in her choices of childbearing or not, pregnant or already having delivered.
Okay. So I do feel from when I was diagnosed, which was almost my second diagnosis 20 years ago, and where we are now with young women and breast cancer, we hear a lot more about it. So give us an idea where we are now with numbers. Is it considered rare for young women to get breast cancer? And what about the subset that it happens, you know, either during or after postpartum, during pregnancy in young women? Is that happening more often? What are the numbers? Give me an idea of the scope.
So young women's breast cancer is not rare when you think of it in terms of cancer in general. So in the United States and countries similar to the United States, so different countries in Europe, Australia, the UK, the percentage of all breast cancers that are being diagnosed in women under the age of 45 has ranged from like 13 to 15%, depending on when you look at the data.
Okay.
So given the large amount of breast cancer in the world, right, there's like 2 million cases diagnosed every single year. In countries like ours, it's upwards of 27, 30,000 women who are getting diagnosed in these younger ages every year. That's not rare.
No, that's not.
By any stretch, particularly when you look at other cancers and how many total cases get diagnosed each year. And then globally, when you look around at our sisters across the world, in some areas, the amount of breast cancer getting diagnosed in those countries, it's a much higher percentage of women who are young. Far East Asia, Sub-Saharan Africa, the Caribbean, different South American countries. So they see a much higher percentage of younger women getting diagnosed than we do. And we don't know all these countries, how many of them are postpartum, but most of these countries where we see the rates of young women's breast cancer increasing, they have both a higher mortality and they have a higher birth rate in their population. So it would make sense that these have a higher likelihood of being postpartum breast cancers. And in the countries where they have collected this data and been able to report out on it, including recent publications from India, Mexico, Saudi Arabia, other places, they are seeing both a high level of postpartum breast cancer and an increasing percentage. Now, globally, women have been delaying the age at which they're having their first childbirth. And the relationship between pregnancy and breast cancer is complicated because all women, no matter how young we are, if we have our first child, we have an increased risk of getting diagnosed with breast cancer. And how long that increased risk lasts depends on how old we are at the time of our diagnosis. So if we are young, under 25, under 30, that risk lasts about maybe 10 years or so or a little bit longer, and then the crossover effect kicks in, and that prior pregnancy now becomes protective against breast cancer. If you're an older mom, such as myself, then both the likelihood of getting diagnosed with that breast cancer is higher in those first 10 years, not tremendously higher, but a little bit. And then I'm gonna have to be about 80 before I will get protection against breast cancer by virtue of having had my children at a bit of an older age. And so, so I think we're taught, even in medical school, I was taught that having children and nursing our children is protective against getting breast cancer, and it is, but that's the second half of the risk story. There's a window where it is not protective, it actually increases the risk. So one of the biggest risks for getting a young woman's breast cancer is actually having kids. Now, we want women to keep having children. We want women to nurse their children. That's not increasing the risk. And we want women to make these right life choices. But we want the medical community and we want women to be aware of this risk. Because in my clinic, where I see things go wrong is young women have a breast concern and they're not necessarily referred in immediately for the testing that we would want them to be because they're pregnant or they're nursing or they're postpartum or they're very young, and it's just not on the radar. It's not on their radar. It's not on their clinician's radar. Now, I've had plenty of women who were referred in like that by their OBGYN or their PCP or their nurse practitioner, and that saved their life. But that's not 100% of the time, and it needs to be 100% of the time. And so that's an education piece we've worked hard on trying to help change so that that's something we don't continue into the future.
Okay. Really, really appreciate that fact. I mean, as advocates, one of the ways we can assist in this is, amplifying that message. But I really, truly appreciate that you're identifying that not only a patient needing to ask questions, but the provider as well. So, since we've been here in San Antonio, you have been very generous with your time, speaking with advocates at several sessions. And I caught a session that you did yesterday, and you talked about one of the most important biomarkers that is free. share a little bit about what you shared with us,
Right.
what a clinician can do for their patient in this situation
Right.
after pregnancy.
So for many, many years, and with good reason, women were always asked, how old were they at the time of their first childbirth? Because that helps predict for the risk of getting breast cancer, no matter how old you are. But how do we define a postpartum breast cancer? Well, you heard me talk about women who are diagnosed after their last childbirth,
Right.
and the number of years from that event to the time of their diagnosis. So it's the time between last childbirth and diagnosis of breast cancer that defines who is in this window of increased risk or not. And women are not always asked, how many children do you have and what are all of their ages? And honestly, if we just had one question to ask women to help really move this forward across all of the research being done in breast cancer, it would be, how old's your youngest child?
Yeah.
And that's how we define this. And it's, we had to create our own database for, been working on this for almost 20 years, but we had to go from scratch because that piece of information isn't in most of the pre-existing databases.
Yeah.
That's starting to change. If you see this evening, there'll be a bunch of posters at the poster session looking at what we call pregnancy-related breast cancer, which is cancers diagnosed while women are pregnant, and then postpartum breast cancer. And so, the field is becoming increasingly aware and leaning in on this, so much so our European colleagues led by Fredo Amont and team and other great colleagues in Europe have put in their European Society of Medical Oncology guidelines that, pregnancy-related breast cancer and postpartum breast cancers are two separate things, and they need to be looked at, and they need to be researched further. So they've leaned in as an entire medical organization to really work on that.
I'm really glad to hear that. Okay, so you've touched on a little bit database research. Can we shift a little bit and talk about your research and particularly your collaborations with patient advocates? And I bring that up because I stopped by the poster. You and your team presented a poster yesterday in the poster session, and I would love to hear just a little bit about what that poster was about.
Yes, so Ellen Landsberger was kind enough to present on our behalf a collaboration where we wanted to really come together and have a unified voice around this research topic, because it is something that the more people who are interested in it, the more people who are spending time working on it, the faster we will get to these answers, and this is what my patients deserve. And, I've been super fortunate. So for 2 decades, Carol Bass has been our advocate in all of our scientific research. And if I know anything about the value of advocacy and research, I think it's because she taught me. Yeah. But over time, I've gotten to meet all these other wonderful women and organizations such as this one that have really helped identify how I should be really thinking about things, because, I've not had to face this disease. I've sat on this side of the desk for many years, and I am very well aware of the fact that this side of the desk is different. Yeah. But I want to hear from the people I take care of, my patients, advocates, so that I can make sure that as we're moving the research forward, we're really hitting the topics that matter most to the people who have had to have gone through this. Okay. And you can only do that by having, not a once-a-year meeting with your advocate, or not, the occasional come to a meeting and talk about things, or, hey, you want to look at my grant before I submit it, but really an ongoing, in-depth series of conversations every year about where are we, what do we need to do, and how can we help each other. How can I come here and talk with you? How can you help me learn and figure out what we need to do next research-wise so that it matters?
Yeah. Excellent. Well, good. And if there's any takeaway, I think, I could sit here for a long time and talk with you, but I know there's a lot going on today, a lot of great information coming out today. So I look forward to hearing more. I'm sure we'll be hearing more from you. But if there's any takeaway, young women worry about pregnancy, they worry about fertility, they worry about fertility treatments. What would you advise a young woman who may have an elevated risk, or what she could do to lower? What would you have a takeaway before we wrap up here?
I'll try and keep it not too long. One thing I want to touch on, though, because again, the interaction with pregnancy and breast cancer is complicated. And you yourself mentioned that you had your second round of this after you had your child.
Yes.
We think it's fine for women who have been treated for breast cancer and well to go forward with having a child if they want to. And that bears also from retrospective data published in the past. Again, my European colleagues have done a great job with this. And then also recently, globally, the completion of the positive trial showing that in ER-positive breast cancers, if a woman wants to sequence off of her hormonal therapy to have a child and then go back on her hormonal therapy, those women are doing as well as women who did not choose to do that and are on hormonal therapy. And that's important because for many years, my field has told women they have to wait till the end of their 5th year or even 10th year of endocrine therapy to be able to consider this. And that's just not biologically relevant for what Mother Nature does to us in our timeline and fertility as we age, particularly if a woman needs chemotherapy as a part of her treatment that can alter some of the timelines of natural fertility afterwards. And so since the majority of our women, at least here in the United States, who we treat are going to be cured, we want to offer them all the normal things of life that they otherwise would have wanted to the extent that we are able to preserve that for them. So when a woman is young and diagnosed and not complete in her desire for childbearing, we want to make sure she gets referred to oncofertility, that they can discuss with her. There's tests they can do to even ascertain what is the baseline fertility. If she's never had a child, we don't even know that. And then there's assisted techniques if there wants to be any banking of genetic material, eggs or embryos, and then a conversation with a physician who is comfortable with this and very familiar with the data about what the timing would look like. We have all these additional therapies now for young women with breast cancer, and some of them are not safe to overlap with a pregnancy. So it really has to be a thoughtful approach, a very individual tailored approach, but not something that I would ever want a woman hearing our data about postpartum breast cancer to confuse that if she had a child after she's been treated, that would increase her risk for recurrence, because we have not seen that. Okay. For a woman who's not yet been diagnosed and hopefully never will be, and is just living her life and thinking about having her family, I think the most important thing is to make sure you know your family history, you know it on both sides of your mom and dad lineage and extended family, and then make sure you have a great relationship with a doctor who you feel listens to you and you're heard, so that if you do have a concern while you're pregnant or in your postpartum years, you know who you're going to go see, you know they're going to listen to you, and that you can have a conversation about getting in for, an ultrasound or whatever it would be to figure out, is this okay? Many women have in-breast concerns after pregnancy and while nursing or after completing their nursing that are never going to be cancer. But we don't want to miss the ones that are, because we want to get a handle on those cancers as soon as possible and begin their treatment, because they can be hard to take care of.
Okay, excellent. Well, for those of your patients that are lucky enough to come see you, we're grateful for the work you do. I hope this message carries not only for us as advocates, but to the healthcare provider community, because I do think, at the really primary care level, OBGYN in the community setting, we've come a long way in 20 years since my diagnosis, but I do think we can continue to raise awareness on this issue. So thank you for all you do, and thanks for the time. I hope we can chat again soon.
Thank you very much. I appreciate it.